Welcome to Moving Conversations, a podcast for movement professionals by movement professionals. If you coach, train, or teach movement, Pilates, or fitness, then this podcast is for you. With more than 60 years of experience in fitness and Pilates, your hosts, Brian Ritchie and Nora St. John, explore the science of human movement, diving deep into the facts, myths, and common misconceptions, hoping to spark thought and conversation about how we view fitness and movement. Now, let's jump into Moving Conversations. And welcome back to Moving Conversations. I'm Brian Ritchie. Joining me as always is Nora St. John. Good morning, Nora. How are you today?
Very well, thank you. We've got a little bit of rain coming. We're about to head out to Pilates on tour in Phoenix.
Yeah.
And that'll be pretty exciting. Haven't been there since 2019.
I was going to say, it has been a long time. You know how we every now and then get in our, social media feeds. This happened so many years ago and this happened. It was interesting, but I got one of those the last time and I looked and I was like, oh, wow. Yeah, it's been a little while.
It's been
a little while. Yeah, since we've been there. So I'm excited. I'm very excited. It's going to be a lot of fun. By the time this drops, we'll have been back and had probably many stories to tell by that point. But
yes. Yeah. And hopefully too, maybe some more guests for our podcast too. We'll see who we can get to. Hopefully there's a few good people there that we can get to chat with us and have a few more guests on. That'd be exciting.
Yeah, very cool. Well, today we want to discuss something that we haven't yet. We want to talk about one of the total joint replacements that we see most commonly, hip replacements.
Mm-hmm.
And we thought this would be a good opportunity to sort of dive in a little bit here and introduce the concept, what's happened traditionally. It's one of the newer replacements in that, or not newer, it's been around forever, but there's a new technique that's only been really, I don't know if it's becoming more popular, but it seems the popularity has grown in the past 5 years or so. So I thought, let's talk about that a little bit so that people who are listening could have an understanding of what goes on in each and, if they have the choice to make, they can make it based on, some good information.
Awesome. What I like to start with is of all the joint replacements, because I've had two things. First of all, I haven't had a lot of clients with joint replacement in the recent past. So Brian's going to be more of our expert on what's called the anterior approach, which is more this newer approach to how they do the surgery. But I do know a lot of people have had it. I just haven't been working with a lot of people with it. And I have to say, if I had to have a joint replacement, I would prefer to have a hip replacement to anything else. I know many, many, many friends, colleagues, clients, family members who've had hip replacements, which have gone just supremely well. Right? Pain goes away. They're able to come back to functioning. Two people that I know, one of them has returned to high-level skiing. One of them has returned to her full fitness activities in every way. So it really does seem to be, in general, a very successful surgery and one that seems to work most of the time. So I just want to bring that up. Like knees, a little more problematic, shoulders, a little more problematic, ankles, really problematic. But the hip is the hip they seem to have down. So I just wanted to start with that. Like if you're thinking about it, not a bad idea.
Well, if you think mechanically, the hip has incredible range of motion. And just if you think about the socket, the ball and socket joint, structurally and biomechanically, it's pretty easy to replicate in a laboratory environment. It's one of those things that you could say, oh, what does it do? Well, the ball fits into the socket.
Right.
And
it's like,
and once it is there, it's not that difficult. In fact, I'm going to, for those who are watching on YouTube, I can actually demonstrate because I'm weird. I collect these things. So I have a little socket here and here's the ball and literally it goes in. This is an actual joint hip replacement that they use. And so those of you who can see it on YouTube, and it gives you your hip full freedom of motion. And that's awesome when you think about it. So again, it's the one joint, unlike the knee joint where everybody thinks of it as a hinge. It's a modified hinge. It's a hinge that actually rotates as well, which is a lot harder to duplicate. Whereas the hip socket is pretty easy to duplicate, in a, structural sense.
It also has sort of more inherent stability. I mean, if you just replicate
Yes.
that joint, unlike the knee joint or the shoulder joint, which don't have structurally much inherent stability. The hip
Yep.
is like a lock and a key. You've got something fitting into something else. The shoulder, you've got a big ball and a little tiny platform it sits on. And the knee, you've got basically two relatively flat surfaces that are sitting against each other.
Yep.
I mean, that's simplifying it, but those are not it. You've got a ball, you've got a socket, and you've got that ability to create a joint that works pretty well from a mechanical perspective.
And you've got a ton of muscle around the area pulling that into the socket from all different
Yes.
directions. It's
Yes.
not just pulling it in one direction, it's pulling it in all different directions and creating additional stability, which is why we need to work on strengthening all of those afterwards just to maintain that congruency so that it wants to stay in the socket.
So a couple of things I like to talk about when I'm working with a client who's thinking about this or has somebody who hasn't had it yet. This is in the pre-phase. One thing is I do encourage them not to. So when do they want to have it done? Right? When is the right time to decide to have a hip replacement? But that's just a question, right? And I find for a couple of things that I think about with that. So for many clients, I'll often start with, and most reliable doctors and surgeons will as well, and PTs will as well. Well, let's see if we can get you relatively pain-free and functional with exercise and movement and conservative measures. Step one. If
Yep.
that works, that can often put off a hip replacement for quite some time. Maybe you'll need one later, but you can at least manage it for a while. So that's one
Yep.
thing. And in any case, even if you do end up having hip replacement fairly soon, prehab, so getting that area strong and functional as much as it can, absolutely will make your recovery quicker and better. So there's no
100%.
downside. Yeah.
And I've seen that every single time. And
Yep.
I've had a number of people, both pre and post. And to a person, when they take their prehab seriously, and there comes a point, normally the people that are going to have hip replacements, what do we usually see as arthritis for a lot of them? We have a wearing down of the joint. We have an arthritic joint. So they have pain in certain ranges of motion. They can't rotate. Usually external rotation is the one that's going to, they cross their ankle over the opposite knee and they can't let that knee drop out. It gets stuck. Now, a good rule of thumb in general, again, this is general. If it looks like they're stuck, there's a difference between getting stuck with a bony issue like arthritis versus a muscle. A muscle, you're going to feel a ton of stretch. If they cross their ankle over their knee drops out and it gets stuck and it's like, I can't go any further. And you ask, do you feel it in the muscle? No, it just won't go.
Right.
That's often arthritis. There's something bony that's
joint limitation.
Right.
Yeah.
Exactly. And that's usually who we'll see have these. And what they say to a person is afterward, almost immediately after the surgery, they're going to say that they wish they had done it sooner. You're going to hear this, almost everybody.
Yes.
But if you get them to take their prehab seriously and to do whatever you can with whatever ranges of motion you can do, because the one nice thing about arthritis is it's self-limiting. It won't let you do what it can't do for the most part.
Exactly. It'll just stop you like you're done.
It just stops you. So you can strengthen them in certain ranges of motion and get their glutes as strong as humanly possible, get everything, their glute med, especially as strong as humanly possible. And if they can't be weight bearing, which is possible, if the arthritis is so bad, you can do all the side lying stuff. You can do assisted. There's a lot of stuff you could still do to strengthen that. But if you can get them standing and it's not too painful, even better. That closed chain environment is much more functional. I have seen 100% to a person, their post-surgery success is sped up unbelievably.
And from a Pilates environment perspective, the reformer is fantastic and the trap table are fantastic because you can be limited weight bearing or decreased range of motion, but you can still get some closed chain activation there if you're doing, like, say, footwork. And then on the trap table or the reformer feed-in straps, you can work all the different angles of the hip. You can work extension and abduction and adduction with some different modifications, but they're not weight bearing, right? You can do an open chain and you can really have them get those muscles active without really putting pressure on there. So it's just a wonderful, wonderful environment for that. And I've had many clients I've worked with have put off hip replacement, some of them for years, just by really being consistent with their practice.
No, absolutely. Absolutely. And the nice thing also about using the reformer and the trap table is sometimes you can actually use as assistance
Yes,
to
exactly.
take some weight off because they may have lost some of that strength, even in something like hip flexion or hip
Yep.
extension, where you can get them to a point where, oh, I have a little bit of help. Oh, this makes it a little easier. And then get them past that till they are able to do whatever they need to do with their own body weight. And then you can always add resistance afterward. It's wonderful for that.
Exactly. But one thing about that, so yes, clients often say, I want to do this earlier. Hip replacements don't last forever, right? So oftentimes if somebody has a hip replacement, let's say in their 40s or 50s, the likelihood of them having to have another one, should they live a while, is pretty high. And it varies wildly. I've heard everything from like 10 to 5 to 10 to 20 to 50. Anyway, I've heard all kinds of different things about how long they last. But that's oftentimes why doctors will encourage people to put that off as long as possible so that that hip replacement will last longer. Okay, so the advantage to that is that. The disadvantage to that is, I'm thinking of one client particularly, one actually friend of mine, not a client, but a friend of mine who really waited too long. Like she was limping for 3 years on that hip. And even after the hip replacement, she still limps. And it's not because of pain, it's because she'd created so many compensation patterns in her body that she just really cannot get out of that compensation pattern, even though the pain and the pathology is managed. So you also want to be a little cautious not to wait so long that you've either caused so much damage you really can't recover from it, or the hip replacement isn't going to do that good a job, or you've created so much compensation in your body that you can't really ever quite get your balance back.
Now, something to think about as well. I had a client 2 years ago, I guess. It was during the pandemic. And he was coming to me and we were doing a ton of prehab for the hip. And one day he came in and I had suggested a doctor for him to talk to and everything. One day he came in and said, I've got it scheduled for this date. Now, this is a gentleman who is in, I'm going to call it discomfort. He's not in pain. He was in discomfort, and not all the time. It just limited him from swimming. It limited certain things that he liked to do. And he's someone who kind of wanted, in his very early 70s, wanted to feel like his kids, like he was in his 30s. And like we all do, we all want to feel, our brain feels like we're young.
Right.
Exactly.
Why isn't my body doing what my brain wants it to do?
Yeah. And he said, I'm doing it. And his wife actually came to me and said, talk him out of it. Please talk him out of it. He's not in that much pain. And I said, why do you want to do it now? I said, you're really not in that much pain. He said, look, I can have it done now and I can enjoy and rehab it and enjoy the next 10 years and be as active as I want to be. Or I can hobble on this, let it get worse and worse and worse, have it limit my life and create limitations for the next 5-7 years, then have it done and feel like I've wasted the last 5 or 7 years. And you know what? I just sat there thinking and thought, that's not the worst. He put some thought into it. So I said, you know what? For your lifestyle, he's very active. I said, okay. And I even told his wife, I said, you know what? I can't argue with him. Yeah. Because you gave this a lot of thought. You want to be active. And we strengthened the heck out of it. It had been for a long time. He recovered unbelievably quickly. I mean, he was one of those super cases.
Great.
He came back and said, I'm doing the other side. And I warned him, you may not recover as quickly. Every side is different. You have to treat it. And the second side was a little harder, but he's now, he's biking. He was biking before he could drive the car. The doctor said, we don't want you driving a car. So he came in biking. I said, you're on a bicycle, but you're not driving. Okay.
All right.
He said,
whatever.
Doctor never said I couldn't ride a bike. So I said, okay, whatever you want to do. But that mindset, there's also something too. And again, he was 70. So the chance of him outliving the joint replacement, is probably slim.
It could be fine. Yeah.
Right. At 45, 50, I know quite a few dancers who have had it done. They're probably in for a revision. They're just time-wise.
Yeah, if they last long enough. One thing though that I do say is it sounded like he had a fairly realistic sense of what it would take to recover. Because the other thing that I mean, so many clients fall into this trap of, oh, it's kind of like fixing the brakes on my car. I'm going to
Mhm.
go in, and oftentimes surgeons encourage clients to think this way, just
Yep.
to be blunt, right? I'm going to go in, they're going to fix it, they're going to put the new part in, and I'm going to be fine and not have to do anything after that. Like that
Yep.
is really the fantasy that so many clients have. Even if the doctor and the PT, because I'm there, have specifically said, you will need to rehab this for at least 3 months before blah, blah, blah. Like all they hear is, you will be fine. Blah, 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 right? It's
Yep.
like Charlie Brown's teacher after that.
Exactly.
So if they have a realistic sense of it, that's fabulous. Then absolutely, go for it. But I do play a little bit of the negative Nelly, just going, you know how long this is going to take to get better. You know how much work you're going to have to do. And if they really are up for it, and I can tell they're up for it, great, absolutely. If on the other hand they're like, well, I don't think I'm going to have to do any rehab after this. It's like, okay. Well, if you don't want it to work as well, then don't do any rehab.
Keep something in mind. I always tell these clients is anytime you cut a bone,
Anything.
okay, a bone, especially bone takes a certain amount of time to heal.
Yes.
Okay. You are a minimum of 8 to 12 weeks of just healing the bone portion. So before anything else, understand that you're not going to feel perfect 2 weeks out. It's going to take time. And in that time, the bone is trying to heal. So when I had my shoulder recision done, they took off 2 centimeters of my clavicle. They told me it's 8 weeks, 8 weeks for just the bone. So we don't want you moving around too much. We don't want you doing too much. Same thing with this. You want to make sure that they have an understanding that the bone does take time to heal, not just the trauma of the surgery, not just the connective tissue, the muscle, everything else that they're cutting into. We're talking about just the bone aspect. So it's going to take time. And I'll tell every one of these clients this, you are 9 months away from being 80 to 90%. You are a year away from being near 100%. And if you get there faster, fantastic, awesome.
Right. But be
But
prepared.
be prepared.
But be
It's a
prepared.
longer haul than people think.
Yeah. 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 And honestly, I mean, I know a lot of people who've come in really strong and had, and made substantial progress pretty quickly. I've
Mhm,
had a lot of people who are pretty back to close to full function in 3 months, 3-4 months.
mhm, mhm.
But these are mostly people who worked their behinds off as
Yes.
prehab, and then also in rehab, that they really committed to it, and they wanted to get back, and they did something every day. They really worked
Yep.
on their home program, and those guys can often make really good progress. So,
Mhm.
just know, like, there's a big range there, but you're not
Yep.
going to be 100%, and you're not going to be able to, like, go back to going on a 3 diamond or a black diamond run
Right.
in 2 months, and just plan that into your life. Like, know, like, this is the next 6, 8 months, 9 months, you're going to just commit to this. And then if you
Yep.
do, fantastic, you'll have good
Yep.
results for the most part.
Exactly. And again, part of that, the reason I tell them 9 months to 12 months is to
Yeah.
set up the realistic expectation so
Mhm.
that they don't come out. Remember, if they are experiencing that bone to bone pain from arthritis, that every time they stand up, every time they move, every time they walk, they have that nerve pain. That's almost like if anybody's had a tooth, an infected tooth or something, it's in the joint and it's in your bones, and every step you take, it hurts. Well, guess what? They cut all that out. So you wake up and that pain is gone. There's other pain you're still dealing with, and there's other
Right.
things.
Yeah.
So keep in mind, one type of pain is gone. And I'll tell you, to a person, they're laying in bed and they move a little bit and they think, oh my gosh,
Hallelujah.
I have no pain.
Yeah.
No,
Hallelujah.
it's different. Exactly.
Right. Yeah.
And now we have to just work toward getting it stronger. And like you said, prehab is a key. If you can do it, if you can convince them to do it, it works wonders. And it's so important. But I also want to make sure that they have in their mind that it's going to be a little longer process than they probably think.
And then they would hope for, right? Everybody's like, I'm going to be
Yeah.
that special person who's better in 2 weeks. It's like, nah, probably not. But it's good that you think that.
Now,
Um,
I do want to
yes.
make one thing, since we're talking a little bit about what happens after the surgery.
Mhm.
I have had a number of clients have their hip replacement and not suggest them going to physical therapy.
Mm.
A number of doctors in the Washington, D.C. area, and I think I don't know if it's driven by the insurance industry. I have a sneaky suspicion maybe it is. And when I talk to the doctors, they all say the same thing. They're going to figure it out. They're going to learn to walk again. They have immediate home therapy right away. They have the home therapy for about a week or two. They get taught how to use a walker. They get taught how to use a cane, and then they just start walking, and they're told, you're functional now. So just keep walking and increase your walking, and you're going to be fine. And the very first person, a gentleman who was a mentor of mine, his brother was told this. And this person is a physical therapist and called me up and said, will you see my brother? Said the doctor will not prescribe him physical therapy. I don't know why. So I said, sure. Came in. He was a coach. The guy was going to be running up and down on the field, the sidelines. He was going to be on a basketball and a football field. He was going to be active.
Yeah. So, he's got to deal with impact.
Right.
Right.
We had and a lot of lateral movement. Yeah. And we got him back 100% without, about 9 months, he was 100% ready to go take on the world. But when I talked to the doctor just told me, look, his body will figure it out. And this is a very well-known doctor in our area who is a very good surgeon. I would have no hesitation, going to him, except for this. This is the one thing where I think, wow, I really wish that they would continue to prescribe a little longer physical therapy. And he's not the only doctor. There have been a number of them. And a lot of them ended up at my door because I worked with them beforehand. And they said, they won't give me PT. Will you help me? And I'm not going to turn someone away. I'm like, okay, is your open wound closed? Yes. Okay, let's work. So don't be surprised.
Yeah. So this brings up, we haven't really talked about like what the surgery is, but we'll talk about that in a minute. But this brings up a situation that we may find ourselves in. And just a reminder of what that situation is. This happened to me all the time too at St. Francis, because we were known as the place for people who things didn't work out so well, right? We were always kind of the place of last resort. Well, if nothing else works, I'll go to St. Francis and see if dance medicine or Plies can help me. And so we often got cases that either again hadn't had physical therapy, or the physical therapy had not been effective, or, they'd been cut off after 4 sessions or whatever it was, and they really were not functioning yet, right? And they wanted to get back to a higher level of function, or they really wanted to get back, like you're talking about with your client, like to coaching, something where they're not just managing daily life, they're really having to manage things that, if I was just incapacitated, even just recovering from surgery and minimal activity for 3 to 4 months, because it's going to take a while just to get up and running and everything moving and strong again. I would want a rehab recovery time in order to be able to tolerate what I'm going to be doing in the future, right? Just from kind of the relative inactivity of being, less weight bearing for a couple of weeks and surgery and all those things. So sometimes you are put in a position as somebody who is not licensed, okay, presuming you are not licensed out there, to be kind of doing the job of really what should be a physical therapist job. Yeah. At least they should be overseeing it. And my only recommendation to you on that is, because if you're like me, that will happen. That happened to me all the time. I had good relationships with some MDs. I had some good relationships with some PTs. And so I had them in my back pocket, as I often say, and I would call up my friend Brian. Actually, his name was Brian too, and say, "Hey, Brian, I got this client. Do you have a minute?" And we'd talk about it, and he'd give me some insight or some help. I had a client who was 2 weeks post-op. I'm like, okay, what are my guidelines that close to operation? Because typically that would be PT time, right? That would still be when they're seeing a PT. That would not always be a time when they're going to be seeing a Pilates teacher, especially one that doesn't have a degree in physical therapy. And so they would guide me. So again, if you find yourself in that situation, get yourself a good back pocket referral network of PTs, MDs, chiropractors, massage therapists, whoever's
Mhm.
really good in your area to help you out in those moments.
I couldn't agree more. We had a physical therapist on staff here or worked out of our facility, and a lot of times I'd utilize her. And she would send people to me quickly and say, "Oh, no, no, you can handle this."
Yeah.
Because a lot of times we can. But again, I do not have a degree in physical therapy. I am not licensed as a physical therapist, and that's beyond my scope of practice. I can do exercise. I can make you stronger. I can do the
Mhm.
exercise component. And I hate to say this, but a lot of personal trainers out there like to say, well, we do the same thing. No, we don't. We are not physical therapists. They know the body much differently than we do.
Yes.
They do a lot more than we do. What I can handle is helping them manage their condition with exercise, and that's what I'm going to do.
Exactly.
And
And that's
for
really
this,
clear.
yes. And as soon as I say that, and I'll tell that to the doctor and say, and a lot of times I will talk to their doctor
Mhm.
and see if the doctor has any suggestions. Or more often than not, I'd say, here's my plan of action. Boom, 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 boom. And I've got enough experience that usually I know what I'm, going to do with this person. And the doctor will either give me a yes or no, or will say, I like it. Also, da 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 da.
Right.
Okay, got
Right.
it. And you put
Yes.
that in. But I
Yep.
want to get the thumbs up from their physician.
Yep.
I want that first because that's going to tell me what happens if there's something bizarre with this client that they haven't told me. The doctor
Mhm.
will. So
Mhm.
before I do anything, I want to get a hold of the doctor and just make sure there's nothing out of the ordinary and that they agree with what we're going to be focusing on.
Right. And especially that soon post-surgical, like you're still looking for
Exactly.
infection. You're still kind of a little bit in wound care. I mean, the wound may be healed, but you're still contemplating like making sure that nothing weird is happening in there because sometimes there is. I think about one client I know who had a knee replacement and was doing fine and then suddenly got really sick and it turned
Yep.
out that there was an infection around the prosthesis and that took forever to manage.
That's
And
one of the rules that we have. Don't mean to interrupt. 100% no open wounds.
Mhm, yeah, absolutely.
Okay. They
Yeah,
need to
it
be
just should they
completely
shouldn't be
healed
in a
from
gym
that.
environment. They shouldn't be in a gym
No.
environment anyway. Yeah.
I mean, one thing I learned a long time ago is two places to get an infection or to get bacteria are gyms and hospitals.
Yep.
So guess what? I am not taking that risk. No matter how clean I keep the place, the risk is still there. So
Mhm.
until they say there's no open wounds, and until I get a thumbs up from their physician, I wait.
Yeah.
I just wait.
So, talking through a little bit of what the surgery is, and Brian can talk through some of the approaches, but very basically, most of these circumstances, they will go in and they literally cut off the head of the femur,
Yep.
right? So, if you want to show your implant, Brian, they cut off the head of the femur, and they'll use a little, and the implant will essentially go into the shaft of the femur, right? So essentially, you've cut off the humeral head, the neck, and often the shoulder as well, or the greater trochanter. So that
Hmm.
you just have essentially something that's going to replace that entire end of the bone.
And
And
it
then on the
usually
other
replaces to about here,
right, right.
right
And
to
then the
the
other
neck.
side, yeah. And sometimes there's a greater trochanter, sometimes there's not. They do different things with that. Um,
They try and
or
keep as much of the greater trochanter as possible for the muscle connection, as long as it
right,
hasn't been broken. If there's a fracture that
right.
happened below the greater trochanter, sometimes they can't save it, but they try to with whatever they can, just because of muscular connection.
Good. Yeah, very good. And then they basically remount the acetabulum,
Yep.
right? And then basically glue a new cup into it, whatever shape and size is necessary that will fit the prosthesis. So they're basically making a new socket for the ball. Yeah, and
Yep.
those two are gonna match up, and they do a lot of work ergonomically and biomechanically to make sure that they're trying to get your legs the same length when you're done and get the biomechanics appropriate for your particular body.
Yeah. What's interesting about leg length is up to a quarter inch, they consider that fine. The doctors, because there's going to be settling to a certain degree.
Mhm.
Uh, I had a physician who was a surgeon, and he said for him, the number 200 was the magic number. If a physician has done 200 surgeries, they are proficient at their job. After that is artistry. And there's an artistry to getting the leg length based on the person's weight, based on how active they are and everything else, because there will be a little bit of settling from the prosthesis in the bone that it'll either sink in a little bit or it won't. What they're going to do is they're going to remount the actual center of the bone, and then the prosthesis sits inside. Now, there's multiple ways that they can do this, either with just cement, where they'll put a type of cement in there, and then the prosthesis, the one I have here, is actually very smooth. Okay, they make that, and they also make a knurled type that is kind of like sandpaper. Okay, now if it's very smooth, the cement is the only thing that's really holding that in. Okay, it's going to be strong day one because the cement is there. Now, if it's all knurled a little bit and like sandpaper, the bone will actually adhere to that. When the bone actually grows, it grows into that. So it actually creates a better adhesion. Right. Some physicians will also use a cement as well as that to make sure they have good adhesion. These are all different techniques, and every doctor is a little different. I've got a number of surgical friends, and I talk to them, and everything from the type of suture they use to the thickness of the gauge of that to everything is all personal preference and what they feel comfortable with.
Yeah.
And when you go in, what they say is there could be anywhere from 3 to 5 different prosthesis there based on when they open you up, they're going to do certain measurements so that they have a wider variety that they can choose from. Then they're going to say, okay, we want this one for the length for this. We want this one for this. They're going to literally take a drill and remount both the bone as well as the acetabulum and get as good adherence as they can with the, like I say, the cement, the glue, and then put it together and let the muscle basically hold it back in its place. And it's the same for an anterior versus a posterior lateral. Okay, from that perspective, what they do to the bone. Now, go ahead.
No, I was going to say, but which is all well and good, but the approaches again, when I was more in practice, it was almost all posterior lateral. Now there's this anterior approach, which have both different outcomes and different precautions. So
and
talk us
contraindications afterwards.
And contraindications, exactly.
The posterior lateral is the one that's been done dawn of time, basically forever. Okay, and literally it's anywhere from an L-shaped 6-inch scar to a 9-inch scar. And a lot of times I'll ask a client when they say they've had a hip replacement, I'll say anterior or posterior. And if they say, I don't know, I say, where's your scar? Point to it. If they point to their side and behind, it's going to be more of the posterior lateral. If it's more to the front, it's an anterior. Okay. Now, with the posterior lateral, it's more invasive in that they have to cut through more muscle tissue. Okay. They have to cut through more muscle tissue, pull more things out of the way to get to the bones.
Right. To get to the joint, which is buried underneath all of that. Yeah,
exactly. The anterior approach, they can move things out of the way a lot more clearly. Yeah. And that's how they used to do revisions. Revisions were done from the front. The first replacements were done from the rear in general. And they decided that the anterior approach was very good for those clients that did not have excessive arthritis.
Okay.
When someone with a lot of arthritis, they'll still usually go with the posterior lateral approach.
So kind of if the joint is too worn,
yes,
they can get into the joint better to clean it out and to work with it from the back than the front.
Exactly. Okay. Exactly. So it's just, I don't know if it's comfort, if they could clean it out better, if they had more room to maneuver.
Right.
I think it just gave them much more of an advantage. Whereas when things are pulled to the side, there's a little less room to maneuver. The anterior approach, the first person I saw with one now would probably be 10 years ago. And it sort of took me by surprise because I thought anterior, that was a revision. They said, no, it's an anterior. It was just done in the front. That was sort of a surprise to me. But I also knew that there was a physician here at Johns Hopkins who was doing a posterior lateral with an even smaller incision. So different surgeons were doing different breakthrough surgeries at that time. You know, they were trying new things. It wasn't uncommon. Now, the big difference for us, because everything up to now is way beyond our scope of practice. It's beyond what we can do. Okay. If I had a choice of the matter, the anterior approach disturbs less tissue. They don't have to cut through as much. But more importantly, the contraindications are much, much less. They say in general, if you have the posterior lateral, what you're not supposed to do, and depending on the physician you talk to, I've had a number of physicians say for the rest of your life, you are not allowed to bring your knee up past 90, internally rotate, or come across the midline. Ever, ever, ever in your life, that has a risk of popping that joint out.
Which means don't cross your leg.
Yeah. Don't cross your leg.
Basically, because you're going to flex it above 90 and you're going to adduct it and maybe externally rotate it once you're there. Right. So that's kind of that's hard for people to not do.
Right. Whereas for the anterior approach, the limitations are they don't want you to do a lot of hip extension and external rotation for a certain period of time. I've heard as little as 6 weeks, as much as 3 months.
Yeah.
And then free game, go for it, do whatever you want. And again, part of that, I think, is because they haven't cut through all of that muscle in the front. The muscle is still there. The muscle bulk is still there. So that's giving you some protection anteriorly anyway and holding the joint in place.
Yeah, it seems to be just easier, and again, less contraindications. Contraindications don't last as long. And again, for the posterior lateral, I've heard everything from, you can never do this ever again to, you can do it after 3, 6, 9, 12 months.
Right.
So it really, there's not consistency in my experience of that.
Not at all.
At all. And so I'm just cautious because, might as well be cautious when these things are coming up onto you.
Yeah. That's my whole thing is it's all about caution. I will, even if they're a year out and they've had a posterior lateral and the doctor says, oh, do whatever you want. I'm still cautious of piriformis stretching. I'm still cautious of certain things that may put them into that position, just sort of in the back of my mind, and part of the reason is if during stretching, a lot of times they're more passive. And
so they're not supporting, right? They're not supporting that joint in an often stretch. You're just passive, letting the tissues move in a certain direction. You're not providing that muscular support or stability.
Right. But if they're actively going through the range of motion under resistance, well, they've got muscle tension to actually help create more stability within that joint. So I will explore that as long as I've got thumbs up from the doctor that they said, oh, they should be fine. But again, in the passive environment, in a stretch position, I'm trying to hold off on that a little bit. It's not worth the risk.
It's not worth the risk. And I certainly would assist a stretch in any of those circumstances, like even just pushing the knee into the chest. Sometimes you'll kind of push somebody's knees into their chest if they're supine. Like I would just not do those. I would let their body tell them when to stop. Right. As opposed to giving any external force on those things. So let's say you've got somebody who is after hip replacement and you're working with them. What are the key things that you focus on?
Glute med, number one.
Yeah.
The gluteus medius, 100%, no questions asked. I mean, I start them. If I get them with prehab, they have the strongest glute meds you've ever seen in your life. I will have them do every single exercise and their homework is every exercise you can imagine for the glute med and the glute max, because those are two that are so vitally important. And when it comes to post rehab, oh my gosh, that's all we're doing for a while. And again, we start with, supine, open chain, all that kind of stuff lying on the table. But as soon as I can, I get them up, I get them standing, I get them weight bearing, and we're going to do all the stuff in that position as well, because they need to know how to use that hip. Because we don't want to see, and you're going to hear this term when you work with hip clients, is a Trendelenburg gait. And it's when that hip sags out to the side. It's the person when they stand on one leg, they sort of ride that hip out to the side. It just sort of shifts out and they can't control it. They can't pull it under their body as well. Or they stand on that one leg and their whole body sort of has a leaning tower of Pisa over the leg, getting that center of gravity to be over their foot. Those are the two things that you're going to see. Got a great story. I had a doctor client, kid you not, physician, had a hip replacement, started seeing me. and we were working on balance. And I still told him he still has a Trendelenburg, and he's arguing with me. I do not. I'm fine. I stand on one leg. I'm fine. 100%. I do both same way. And I said, really? So I pulled out, believe it or not, this is a while ago. I had a Polaroid. Okay. So I said, all right,
this is a while
here
ago.
we go. Click. Took one picture standing on the good leg. Click on the bad leg. On the bad leg, he leaned so far over that leg, the surgical leg, that his body was, I'd say, at a 45-degree angle, maybe a 50-degree angle over the leg.
Holy moly.
And he couldn't see it. But when I showed him the picture, it was, oh my gosh. And I said, now you see what I see. And he said, gotcha. Okay, I'm with you. And then from there on, smooth sailing, because he could see it. Now, with our iPhones or, Android, whatever you got, you take a quick snapshot, you just point it out there. Like, oh, I see that.
Yeah.
So I use mine all the time for that, because if I see something, especially from behind where they can't see it, I can snap a quick picture, because I have a couple clients who like to argue with me, who, when I'm telling them to stand on one leg and pull that hip in, I am. Well, maybe a little bit more. I am. That's as far as it can possibly go. Well, snap a picture. Really? And they go, oh, okay, maybe. So just a picture can be worth 1,000 words for that.
So this brings up something that I just wanted to bring up here, which is, yes, I focus on that in the Pilates environment. I really work so much on alignment also, because I find that hip joint does not always work like it used to work. And so clients have to figure out, how to flex the hip, how to extend the hip, how to abduct and adduct the hip.
Yeah.
And just what does it do? So, and that for me is where the reformer, footwork on the reformer is fantastic, because I can really say, okay, let's, if that knee's really coming in, or that foot's really going out, or that hip is dropping, that, Trendelenburg issues, I can work with all of those, and I can put a little band around the outside of the leg, or put a ball between the knees, or whatever, to try to help them understand where that hip is now. Because the sensation, the proprioception, is often pretty off for a bit after a joint replacement, just because it's a different joint. It's not the one you're used to, and it may not move quite like you're used to. So,
yeah, some people don't realize the amount of proprioception that is within the joint. You have a ligament, proprioceptive ligament in the center of the hip. Okay, that goes from the ball into the socket. When they do the replacement, that is gone. And that was a huge amount of proprioception of where your leg is in space. So for us, you tell someone to flex your hip to 90 degrees, they could do it with their eyes closed. You tell them to externally rotate, they can do it. Someone who's just had a hip replacement, even if it's a year old, may not be able to do that yet. They haven't always retrained the muscles to get the same amount of proprioceptive feedback to allow their body to be in the space they think it is. So you're absolutely right. Alignment, getting them to be able to feel and get the compensation of the other muscles proprioceptively to know where the joint is in space is huge. It's very important.
And especially if they're going to go back to something unpredictable or very forced, like skiing or running or dancing, something like that. If they're going back to something which really involves unpredictability and multiple planes of motion, all that kind of stuff, that proprioceptive awareness is kind of critical to them being able to do that successfully, both from a safety perspective and from a performance perspective. So I work a lot on just, where is my hip and what is it doing, and trying to feel that.
Yes. The other thing that I try and get them to as soon as they are ready. Okay. Again, I take them from supine prone, lying down, get them standing, get them into functional activity, standing up, sitting down, walking upstairs, then I want to get them away from just sagittal plane. I want to get them into frontal plane, sideways walking, going up a step sideways.
Yep, exactly.
Then rotation, taking a step, turning 90 degrees at the same time, allowing that external rotation, allowing the internal rotation as they step back. So their body begins to work in 3 dimensions. Because how many times have we had the robotic client that after a hip replacement, they move forward and back really well. But if you tell them to turn a corner, they walk and then they turn like a robot, and then they walk and go straight again. And
exactly.
if you want to at all get them back to activities, you need to get that rotation going, and to be able to do internal and external rotation, as well
And
as dissipate forces sideways, laterally.
yeah, and not even, I mean, honestly, not even just to get them back to high level performance, but just to be safe
For
in an
life.
ordinary, I mean, for life. It's like
Yeah.
if you're not confident with a lateral move or an oblique move or anything like, or a diagonal move, front, back, or side, then the more likely thing is that you won't make that move, and you'll fall over or you'll trip.
Yeah.
And that may cause a damage to the other hip or other troubles. So yeah, just getting them back to strengthening. To your point, glute med and the whole hip apparatus, and then really working on functional movements. Again, up and down a small step, and up and down from the seat. In and out, like on and off the reformer is always a great place to do that. I do a lot of feed-in straps also, of course, because that's going to get the hip going in 3 dimensions and really works the proprioceptive quality of it. And I can also really see, especially on the trap table where the legs are independent, if the legs are working similarly or not, because oftentimes they really aren't. And they don't know that. They'll bring them down toward the table, and one will go almost to the table and one won't come anywhere near it. And they'll think they're going the same distance. So just working on that proprioceptive feedback and that awareness along with all the strengthening.
Yeah. I also want to put this in here. Don't forget hip flexion.
No.
Because a lot of people have a tendency to believe our hip flexors are the bad guys. So they're always tight. Well, tight muscles are often weak muscles, and people forget that. And after surgery, you're going to be working on your glute med, you're going to be working on your glute max, but hopefully they've done their physical therapy, and that's a lot of what they're going to be focusing in on. A lot, because those are super important. But don't forget the anterior as well. Don't forget hip flexion. It's very important that they're able to sit back as they do a squat, because people forget that hip flexor assists in the squat, because it does allow deep hip flexion. So don't forget to work those hip flexors. Super
sitting
important.
Down, getting in and out of your car.
That's a big one.
Getting on off the toilet.
Time.
I mean, all those involve a certain amount of hip flexion. And that's really where the posterior lateral approach, where you're not supposed to flex the hips beyond 90 degrees, is like, really? You at home, try sitting down onto a shortish, like a lowish stool, or even just, your chair, without flexing the hips beyond 90 degrees.
Yep.
It can be done, but it usually involves some upper body assistance.
Well, think about a car. If you had a right hip replacement and you're going to drive a car, you're going to sit down, you're going to already be at 90 degrees. You have to lift that foot, that leg into the car. You have to lift it above 90 degrees. There's no question.
Yeah. And if you're in a sports car, you're going to be sitting below 90 degrees.
Oh yeah. And that's when I will usually see my clients who haven't worked their hip flexors lift with their hands. They lift the leg with the hand to put it inside, then they lift the other side. And they've been doing it for so long, they don't even realize they're doing it.
Yep.
So again, that's something that I want to remind them of. Okay, we need to work these muscles. We need to get them strong as well.
And just to put a little more point on that, for most people, not people with hip issues, for most people, they're really weak in their hip flexors.
Yeah.
I mean, I would say, especially as people age. And oftentimes, like with a lot of my clients, I'll have them just standing and doing a simple marching exercise, trying to get that knee above their hip. So they're going beyond 90 degrees of hip flexion. And they'll be exhausted after 4 reps. And this is somebody who's pretty active, pretty physical, pretty functional. So it's really important. And you don't have to work high. You don't have to work any resistance at all. I start with like supine marching. So that's gravity is really almost assisting it, and just bring it up to 90 and down, and 90 and down. Then sitting in a chair and just lifting it up, kind of like you're just marching on the ground in a small range of motion. So gravity is resisting you, but it's a small lever. We slowly build that up.
Yeah.
For many of my clients with hip flexor issues, but after a hip replacement, I want to make sure that they've got some of that, not the range necessarily, but they've got the mechanics of that working for them.
And what you'll see sometimes is if you have them on the reformer or even in a squat, you're going to see they go into a big posterior tilt. They're going to tuck their tailbone under because they're
rather than flex. Yep, exactly. Rather than flex the hip.
Yep. What I love to do is put them on the reformer. and put a decent amount of weight to start with, a moderate amount, so they can feel that they're pushing and coming back in. And then I begin to reduce the resistance. So now they have to actually pull their body back. They actually have to, they keep their feet in contact with the foot bar, or if I put the jump plate on, whatever. But they have to pull themselves back in. So it's an introduction. And I really cue hinge at the hips, hinge at the hips. That way they understand they're trying to bend from their hip joint and not from their back. And I find that's a good way to sort of wake that up and remind them that this is what we're going for. And soon after, give it a couple weeks, suddenly they're sitting down and they're saying, oh yeah, I can actually, you can see it, and they can feel that they're actually able to sit back, and actually hinge from the hip.
Exactly. And that's an important thing to get back. Because the other thing too to think about is, if there is a real big difference in the two sides in terms of hip flexion, that also means you're just going to be putting unequal forces through the pelvis and then through the spine. And I've had, more than one client who had a hip replacement, even with pretty good rehab, ended up then with a back problem just because the muscles were trying to readapt to everything, right? Or something else was compensating. So the QL might get tight on that side. The psoas might get really tight on that side. Piriformis might be a little overactive. So a lot of things are going to try sometimes to do the job that they're not really designed to do, or they're not strong enough to do it yet, right? So working on all those pieces.
Well, what I've also seen is people, I've mentioned this before and I'll say it again. A lot of times the loudest painful body part gets the most attention.
Yeah, absolutely.
So if your hip, your knee, something has arthritis, and every time you take a step, there's pain, that's what you're going to feel for the most part. And I found that you'll avoid certain ranges of motion and certain things like going upstairs, where instead of bending their knee or bending their hip, they will hike their hip to get their leg up. So they're really using their QL, they're overusing their back. Well, after the surgery, they haven't corrected those biomechanics. So they're still walking up the stairs funny, and suddenly their back starts hurting.
Yep. It's like the client I was talking about.
Yeah, everything else is calming down, but now that's talking super loud, and they're like, well, why am I hurting here now? Well, now we got to erase all those compensations and actually, strengthen that. But you were doing that before.
Yeah,
you're just now it's talking.
Now it's talking because talk. Yeah, exactly. Because damage number one, like number one priority in your brain has been taken care of. So number two priority starts to talk. That's always what happens. Yeah.
Yep. Yeah.
So again, generally successful. There's a couple funky things that can happen. So one of them is just trying to really regain good, as balanced as you can, functional strength through the hips, and then through the legs, through the back, through the core, the whole system. But Brian, there's also sometimes some things to look for in terms of issues. And one thing I just want to bring up is sometimes clients do dislocate their hip replacement. I've had a few clients who've had that happen. And they usually know it. It's not usually subtle. It's like, I can't stand on my leg anymore. And oftentimes it's after a fall or something. Doesn't usually happen just in ordinary life wandering around, but maybe they fall or their dog runs into them or something like that. So just to be aware of that and to listen for any signs of things getting weird. And then sometimes too, there's can be some nerve damage too. Brian and I were talking about this right before we got on. And so being aware that sometimes the hip's better, but they've damaged some nerves sometimes in the process of the surgery, and that can be pretty debilitating over time. So just be aware of those things may come up.
Yeah. Remember, when they're cutting into the tissue or even moving it aside, there's nerves there. Yeah. And you've got some pretty big nerves. And if they traction off that sciatic nerve in the posterior lateral approach, it can cause problems down the entire leg. And in the front, there's a nerve we were talking about, the lateral femorocutaneous nerve, that sometimes gets nicked during surgery. And that can cause some numbness, tingling, pain that doesn't go away. I had a client who had it done and had the anterior approach, had that nerve cut, and he is miserable because he doesn't have the joint pain, but he has this, he says it's about a nerve-sized football shape of numbness, tingling that never, ever, ever goes away. and it can be pretty distracting and it's persistent. It's always there. And again, we were looking up the numbers, and anywhere from the total hip replacements about what 1% to
It was
3
like
points.
0.6 to 3 or something, and in a revision, it
Yeah,
could go up to 6 or 7, so it's not that
so
common, but just something
not
to
that
be aware
common.
of. You know, something just to keep your eye out for if you're working with somebody post hip replacement.
Yeah. And now I will say this, sometimes that nerve, if they do have a problem with the nerve and all they've done is traction it, sometimes the feeling does come back. The issues, but it just takes a long period of time. Other times may not, especially when they've cut the nerve. Sometimes you've got what you got, and it's just something you're going to have to deal with. And as a movement professional, we have to sort of get them beyond the fact that they're thinking, well, all I can feel is this, all I can feel is this, all I can feel is this. It's like, yes, but you can still move your body. So let's figure out what you can do and focus on that. Notice you can go into a deep lunge now. You can do this, you can do that. I know the pain is still there and I know the discomfort is there. However, you are functional. You can go back skiing. You can do all of the things you've ever wanted to do. I'm sorry that this is still there, but there's not a whole lot more we can do for that part of it, but we can make you more functional.
Exactly. So again, hopefully, if you have a hip replacement, if you're working with clients with hip replacements, hopefully you've gotten a little something out of just what we've done. So prehab being really, really important, as much as you can encourage clients to prehab. And again, these are generally very successful surgeries. Talk to their doctor. Make relationships with local people that can really help you out with understanding
Yes.
what you should and shouldn't do. Really critical. And then in the post rehab phase, whenever they come to you, and this could be this could be shortly after surgery. This could be 3, 6, 9, 5 years after surgery. I often find I have to work on the same things.
Yes.
Sometimes a client still has deficits in terms of glute medius strength, in terms of balance. I focus a lot also on balance,
Oh, yeah.
and just getting those biomechanics to be as balanced as you can, like you do all the time. You just have to do it with somebody with a hip replacement. It's not
Yep.
that different. You're just focusing on that whole piece.
Yeah. Just think of it this way. It's more unilateral. One side will be
Yeah.
working properly, the other side won't be. So it's all the stuff you've been doing. It's just one side will have a lot more of a deficit than the other.
Yep.
And you can get it back. You can get it just as strong. I've had some clients whose that side actually becomes a little bit stronger if it was their dominant side to begin with.
Yep, it'll return to dominance,
Yeah.
which is great.
Yep.
That's absolutely exactly. And that's the thing. I mean, that's the thing to take away from this is 95% of the time, these are unbelievably successul.
Yep.
Again, with some work on your part, you can really come back to wherever you want to go. So, good luck with that. And we hope you and your clients are successful.
Yeah. Well, we covered a lot today, and hopefully everybody will have a clearer picture of what's happening, pre-post surgery and what to do for it. If you guys do have any questions and want to reach out to us, you can do so at movingcombos@gmail.com. Or if you have a suggestion for a future episode, please give us a ring. Let us know. Our social media is also Moving Convos at Instagram, Moving Conversations on Facebook. We're posting every week or so. We've recorded a lot of stuff. We're going to be posting a bunch of exercises that go sort of in conjunction with some of the topics that we've talked about. So you'll be able to see some handy dandy, tidbits here and there. And we'll be doing that even more in the future. So be on the lookout for that. And yeah, for Nora St. John, I'm Brian Ritchie. And we'll see you guys next week.
Bye, guys.